And we're back.
Hey.
This is Healthier Ever After. We are continuing our conversation with Caitlin. Bring her on here. Hello, Caitlin.
Hi.
Welcome back. Here we go again.
Perfect.
Excuse me. Just as a reminder, we talked last time about kind of the landscape about how we got to where we are with female hormone replacement and kind of what went wrong for a couple of decades after the Women's Health Initiative. So tonight we're going to talk a little bit about kind of just what happens, what maybe an individual woman might experience, in general over the course of her lifetime, and why this is an issue that we even care about when we're talking about health and wellness, right? And so again, very important that you discuss this and any medication, hormone replacement, exercise program, weight loss medication, whatever it may be, that you discuss that with your medical provider. Anyway, let's jump in. So I just, as we were talking about starting this, I just, within the last, week, I heard about this. You hear people come in and they say, I have PCOS, polycystic ovarian syndrome. And I think that there's been something happened like just recently on May 12th, 2026. And I just wanted to read a little statement about that because something happened that I think illustrates a lot of what we're talking about here tonight, especially anyway, there's a coalition of 56 patient and professional organizations on May 12th, 2026, after years of advocacy and research, talking to over 22,000 patients and clinicians. This includes the Endocrine Society as one of those 56 organizations. They formally renamed polycystic ovarian syndrome, or PCOS, to a new name of polyendocrine metabolic ovarian syndrome, and so PMOS. For 3 years, both of those terms are going to be used, but so you'll hear that. But I think this is an important, it's just a little name change, but I think it's an important distinction that talks about how this is not primarily a condition of cysts on your ovaries. This is a complex, multi-system hormonal and metabolic disorder. And so the name change, I think, reflects that. And I think that kind of leads us into what we're talking about today with women's health. I mean, because it changes over the course of a lifetime. And so let's talk about that a little bit.
So, Caitlin, my question about that for you would be, with PCOS now renamed, what do you think they're trying to get out there? Like, what's the idea behind that, especially as someone that deals with this so often in practice? So what's the reasoning you think that they're trying to aim in order to like change the name, in order to move forward and maybe address this differently?
I think there's a couple of reasons. I think they're not telling us health providers who take care of women primarily, they're not telling us anything new. The way I would describe back when I had a patient that would come in with PCOS, I would say, this is a metabolic disorder that sometimes affects ovaries. It was
rather than the other way around.
Right. It's not the ovaries that affect the rest of your body. And so, because there's some women that come in that have every marker, high insulin levels, all these things, but they've never been diagnosed with the chain of pearls ovary on ultrasound, which is a diagnostic criteria. So it's like, so they're frustrated because they don't fit in any box and they feel like they're miserable. They have all these symptoms, right? So that's how I would explain it to women. It's still tricky, but I think one of the biggest things we're going to get out of the name change is that we're finally going to have the backing of endocrinologists. We're going to, it's not just an OBGYN, reproductive health problem. It's not just oh, you can't get pregnant, because that's traditionally what we've always cared about with women. We don't really care more about quality of life and optimization. We only care if they can have babies. Well, one of the biggest reasons for infertility is PCOS, or this, what we've named it now.
Well, so having the word metabolic in there, just
we're going to get a lot more
little piece of information that this isn't about just ovaries.
Right. It's a metabolic condition that you sometimes see issues with the ovaries. And so that's how I described it to my patients. And I think that we're going to get a lot more specialties weighing in and saying, hey, wow, I never thought of it this way. This is really affecting every cell in the body, how it metabolizes all sorts of things, including sugar, and uses our insulin and things like that. And also, yeah, we do sometimes see higher testosterone levels, which causes acne and facial hair growth and things like that. And those are life issues for women with PCOS. It's really hard to battle those kinds of things. So I think that, like, hopefully we're going to get a lot more specialties that start weighing in and saying, okay, this is an us problem. This isn't a them problem. We all have to work on this together because it affects such a large population. And, when we first found PCOS, some of the first ways we realized it was metabolic was there was these women with type 2 diabetes who were fairly young. They put them through a trial when we finally had to start using women in trials, put them on metformin to see if that would help with type 2 diabetes. And a bunch of them turned up pregnant. That's how we found out this was a metabolic disorder. Like, talk about backwards. But, that's how we understood, wow, the ovaries are actually working better because they've been insulin resistant. They worked backwards on that one. So it's just one of those things that, when women's health isn't a priority, and not just, I love increasing maternal and fetal, infant birth rates and survival rates. I love that. That is not my fight at all. But just that last half of your life from 40 on till 84 is the current women's health life expectancy in Southern Utah. That's a long time to be disregarded. So I feel like it's a huge win for women's health. We're finally saying, thank you. You're looking at our specific women's health issues a lot closer, and you're finally getting other specialties involved, and we're going to finally find some root causes and have better treatments. There's very few treatments for PCOS and, this condition now, even right now. So it's going to be
Awesome.
a good.
Okay, so let's talk about kind of the lifespan of a woman.
Okay.
So, because there's
like, we talking embryo.
Like, let's start with, in the 20s and 30s, those are referred to as the reproductive years, right?
Right.
Because you can have babies.
Yeah.
And so estrogen, it's not, we call it a sex hormone, right? It's not just the girl hormone. What is it doing across the body? Like, it does so many more things than regulate a menstrual cycle. This is what kind of how people normally think about that. But we're talking about it. It supports your metabolic health. It improves insulin sensitivity. You talked about that just a little bit. It helps maintain lean muscle mass. It distributes body fat towards the hips rather than the abdomen. It protects bone density. I mean, there's a lot of things that are happening during those years with estrogen. Maybe just talk about that a little bit, like why.
Yeah. Well, it sets us up for the rest of the life. But I mean, at the basic level, biologic, human level, estrogen, what it does is at the beginning of your cycle, it peaks and it's growing the endometrial layer, the layer of the uterus, to build the nest for the baby if the egg gets fertilized, and so it can have a place to implant. That's an important distinction because it's growing. It's building a nurturing, like, blood rich environment for this fetus eventually, right? If that were to occur, if that's what we choose to have occur, right? So not only is it like nurturing this layer in the uterus eventually, and then estrogen dips and progesterone takes off, but like all across the body. I explain this to women a lot. If you picture a cell, even just soccer ball looking thing, and you picture these little spikes all over it, this is a very basic concept, but you've got receptors all over these cells. And sometimes they're for insulin and sugar, and sometimes they're for different hormones. There's so many things that the cells need. It's kind of like picturing a receptor as a lock and the hormone as like a skeleton key. And when the skeleton key's walking around and it finds the right lock, it unlocks it, and it tells the cell what to do. So there's so many hormones. I mean, thyroid hormones, obviously, there's a lot going on in a cell, but these cells don't know what to do. They don't know homeostasis. They don't know the calm, normal functioning unless
there
these
are
hormones.
receptors on all kinds of cells throughout your body for estrogen. I think that's the
all
key,
over.
key thing, right?
Yeah,
it's affecting
that's a
all kinds
huge
of
key.
systems.
Exactly. And now that we're seeing, hey, wait, statistics are saying frozen shoulder, for example, in females, or frozen shoulder in general, the condition of frozen shoulder, so shoulder soreness, pain, inability to move it, it's really restricted. even without injury. So that's typically, it's a diagnosis of exclusion. So we're making sure there's nothing else wrong. But even frozen shoulder, they kind of saying, hey, most of the women with frozen shoulder are like over 65. Why is it women over 65? What's going on in their life? And they're like, oh, wait a minute, they don't have any estrogen. So they're starting to find all these using statistics and good extrapolation data, but they're finally starting to figure out there's a lot of conditions that are primarily female that tend to happen during hormone imbalance or withdrawal of hormones. And so now we're understanding, when they went in and started biopsying the cells in a shoulder, they go, oh, they have a ton of estrogen receptors. Why would you have a ton of estrogen receptors in your shoulders and in your knees? I don't know. I guess just lubricating and moving shoulders and joints or whatever. But it's not just, the lady parts. Those need a lot of estrogen. There's a lot of blood flow that needs to move around down there. It's, urethra, it's vaginal tissue, it's all of that, because like that's a huge part of reproductive needs, right? But there's also women who say, my teeth are loose in menopause. My teeth are moving. I need braces at 50 years old. Or my eyes are all of a sudden going weird in my 40s. That's a main thing too. But that's also a very female thing, because our tissues and everything's not tightening and moving.
So even though we call this the reproductive years, I mean, not all women are able to, not all women choose to have babies, but that doesn't decrease the importance of properly regulating or making sure that you have good levels of hormones.
And understanding that all your cells need estrogen. This isn't just about, do my lady parts, are they sore? This is not just that. It's really about every cell in your body needs estrogen. So getting the most women who are safe enough to use it, systemic estrogen at appropriate doses and appropriate monitoring, is essential, because it's going to help all the cells. It's going to retain muscle, which is your metabolism. Literally part of your what's eating and using calories in your day is just maintaining muscle. It's going to help retain bone. It's going to help with muscles, everything, all sorts of things. Even women
cardiovascular system is huge.
Oh, yeah. We're going to prevent cholesterol and like insulin resistance. So it literally is a systemic problem. We can use topical local stuff, but really the most women get the most benefit from systemic estrogen, and there's very safe methods and all the things for that.
Caitlin, I'm going to put you on the spot a little here. So for someone in these reproductive years, and I'll ask this, maybe into the perimenopausal time frame as well. Like if someone's earlier on, like in those more reproductive years, typically when we don't really think about women and having hormone issues or problems, what are some of the things you're looking for as a provider? Just like I'm just having menstrual cycles and I feel a little bit off when I'm, PMSing or things like that, versus actually I have a hormone problem. Like what's the things that you're like, hey, these are the things I'm seeing, like, I don't know, weight gain or mood or
normal fluctuations versus something going a little bit.
What are the outliers that you're like, hey, you have a problem you need to look into versus just, hey, this is the regular stuff?
I call those vague symptoms versus smoking gun symptoms. And that's how I present it to my patients. There's vague symptoms like I'm gaining weight. Well, that could be some thyroid issues, which is a hormone problem, but not necessarily sex hormones. It could be stress levels. It could be poor eating, could be poor diet. You know what I mean? It could be a lot of things, right? So there's other symptoms like, man, I'm just kind of sleeping bad. We can get into that later. There's different things, but then there's smoking gun problems. Like I'm growing facial hair for a woman. That's a smoking gun testosterone problem.
Yeah. You're like, this is obvious.
Yeah. Nope. That's a big one. That's smoking gun. And then like I'm having insomnia problems, and I say, tell me about it. And I can almost finish their sentence. I can say, are you falling asleep dead at 9 p.m. and you're waking up at 2 a.m., 3 a.m., 4 a.m., wide awake for no reason? Like not like something woke me up, like just out there. And they're like, how did you know? It's been every night.
You just described me.
No, that's progesterone. That's smoking gun progesterone. So there's all these things that in my mind, I'm listening. So it's a really good, taking a good history with my patients, just sitting and talking. My visits take an hour on these at least, because a lot of it's just talking and listening. It's 80% listening and 20%
going on with
because
how they
And you
feel.
got to understand, most women have kind of gaslit themselves into this for a few years. And they're like, well, it's probably because of this. Oh, it's probably just
Yeah.
because I got to
Well, how
pee
long are
every,
they told? Well, it's just normal.
right.
You're
Like,
just hormonal,
mhm.
Yeah.
Or they get their labs drawn by their primary, which bless their hearts, thank you for checking them. But they get their labs drawn by the primary, and the primary says they're normal. Well, they're normal on the lab slip within typical ranges, but we
Right.
now know those are not optimal. And then when you can look at them in ratios and you can say, you can tease it out. And I mean, Greg, he probably remembers, but there's one day he was telling me about a patient we both work on. And I was like, what is going on with her cycles? It's weird. And he's like, what? They were all normal. I'm like, nope, she hasn't had a period in months. And sure enough, I go, but they were normal in the labs. And I go in there and I talk to her and she's like, how did you know? It's been like 7 months since I got a period and I'm not even 35 or whatever. So really you can look at labs if you're practiced enough at it and you can say, no, these aren't making sense. Something's not right in the body. And and I've had women cry and just thank me for saying like, wow, thank you for not just telling me all these labs that I spent all this money to get drawn are normal, because I'm not normal. I feel terrible and
Yeah.
I'm not myself. So I
Well,
think that there's smoking gun symptoms that I definitely
yeah,
watch for.
I
And
like
that, it's definitely like, and then there's some vague ones that I can say, well, it could be a hormone thing, but it could be all these other things. When there's women coming in their 30s and I say, have you had a hysterectomy? Because that typically puts you into perimenopause 5 years earlier on average than any woman with a uterus that has a uterus already. It's still, I mean, and so there's all these questions. What did your mother's periods look like? When did she go into, because there's a lot of family history genetics involved as well. If they've got a history of endometrial cysts and things like that, there's lots of things to it. But when somebody comes in their 30s and we go through symptoms and I say, hon, I think it might be this, 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 this. We could check some labs, but I have a strong suspicion this is XYZ. Then there's some women I'm like, oh, honey, we can check some labs. We could treat off symptoms. I personally like a little baseline labs. I like that to be able to say, okay, we've locked in. Now let's treat you. Let's get you treated. So it's different for everybody. But those are
okay.
my
So
things.
I
Those are
just
my red
added
flags.
a question to the questions I will never know the answer to. What were your mother's periods like?
Yep. Someone asked me that, it's going to be,
I don't know.
well, I was born at some point.
She had those?
She had those? I don't want to know. No.
My mom doesn't have periods. She's my mom.
Right.
Most women of your parents' age range and a little bit of mine didn't even talk about periods. Most women did not find out how to use a tampon or use a maxi pad from their own mothers in my generation, in my culture.
Because just understanding, like we kind of say that in jest a little bit, but just understanding this hormonal cycle that is normal. These variations on a monthly cycle within you, but there are more effects. It's not just a mood thing, right? Like it can increase. When we talk a lot about weight loss, right, and general health, and those fluctuations can affect your appetite and your fatigue. And it can increase your cravings and reduce motivation to exercise. And so just understanding that, I think, is helpful to know that some of those feelings that are real are not just you being lazy, or 100%. It's actual things that are happening with your body.
Right. Well, the number one symptom the first symptom I usually get from women is I just don't feel like myself. The number two symptom is I sleep like crap. Can I say that on here? And
this is crap. Yeah,
you're
good there.
I think that literally when their most pervasive symptom, one of their most specific symptoms that they can walk into is, I'm falling asleep at 9 o'clock, but I'm waking up at 2, 3, 4, and nothing's wrong. I don't gotta pee. It's not, I don't know. And I'm wide awake and it's demoralizing. When you just look at just the symptom of sleep, statistically, we're going to be eating more carbs the next day. We're going to be dragging. We're less likely to do exercise, physical activity. Our mood's going to shift because we're dragging. Biologically, we are built to eat when we're sleepy. It's how it works. So just that one symptom can break down so many different ways. And a lot of women are like, if I improve my sleep, and I never promise anything, but if we work on this sleep, maybe we can just get you feeling a little bit better, make you have a little more motivation to move through the day. And you're just like, wow, my body makes a little more sense. And what, as we're working through a lot of
And then it
things.
just
So that's
tweaks all
usually the
those other
first place I
things.
start. Yeah.
Like, you know, makes it a little bit easier to not
Hmm.
overeat or, you
Right.
know, whatever
Get out
exercise.
and get your physical activity. Because, you know, a lot of women, that's usually the number three thing I hear is, I'm just gaining weight. And I've always been able to like just work, exercise, diet, and just eat my stuff. I've never gained weight my whole life, except for maybe when I had babies, normal weight gain, you know,
Yeah.
but they're like, I've always been able to lose it. And these last year or so, and they're frustrated. And some women are going into dangerous calorie restrictions because they are type A girls who know how to get stuff done. The math is always mathed for them and they can't make the math work. So they're getting a little dangerous. And I have to say, hey, hang on. There's other variables. We can work on it. We got to get you back into homeostasis. Let's see if we can work on some stuff. So it's really, it's a big conversation for women. And I tell them, hey, you know, like it's not just one quick fix all, but if we can get you going back into it. And I think that's why it's so important to treat when someone's perimenopausal, because when somebody comes in and says, my sleep is garbage, all of a sudden, hey, it's a lot easier to fix one symptom and work on that through hormone replacement instead of hitting them with all these heavy sleep aids and all these things. But if we can restore that a little bit, then, you know, a year later when they're like, okay, I've got another symptom that's maybe more estrogen, I'm like, oh, we got it. We can add things in slowly instead of this woman who's ready to give up, you know, in full-blown menopause, who's miserable and every life is shutting down. That's a lot of things to work on because there's all these hormones and different
So
things.
you mentioned, so it's perimenopausal period. So we talked a little bit about reproductive years, and then we move into perimenopause, and that's usually a state, I guess, or
yeah, it's a collection of
that
symptoms.
kind of starts in the mid 40s usually. You mentioned if you've had a hysterectomy, it could be 5 years earlier than that.
On average, yeah.
We'll say about mid 40s, you get into what's called perimenopause, and that can last a few years. It can last more than a decade.
7 to 10 on average.
So we often, you know, we say, like, the way at least I was growing up, menopause was like an event that happened. You're a female, you can have babies, and then you have menopause, and then you don't have babies.
No period.
Right. And so we talk about it like an event, but this is an
event, like a party.
I like that perimenopause is really how we talk about that, because it is a 7 to 10 year process. And it's not just a gradual decline over that time of your estrogen. It's craziness. Like it's up and down,
it's chaos.
and it can really change and affect like all kinds of symptoms.
It's really pretty crazy. Like I always tell my patients, you know, and this is why, you know, dragging a woman in at 25 and saying, what are your hormones? You're the best of your life. And what are all your hormones looking like? Because it changes throughout the month, right? Well, then you take a perimenopausal woman, and we would never do this, but if we did, if we drew their blood and her blood and checked all her sex hormones every day for 30 days and graphed it, it would be very chaotic. It would be like, up, down, up, all around. And then the next month we think, oh, it's probably going to show the same pattern. Nope, all different. So it's really chaotic throughout every month is different. Some women might be like, oh, my period length was 22, you know, my cycle length was 22 days, and next month it's 29 days. And the next month you know what I mean? It's all over the place. And so I really try to get women away from this idea of like, we can lock it in. No, we can just bring your threshold up, your symptom threshold up. We can kind of gently decrease that so that when you're hitting these chaotic lows, we're not dipping down into that threshold of symptoms because your levels,
where you would be symptomatic.
Right. And so if we can with hormone replacement, if your symptom threshold is here and you're dipping down and like, oh, hot flashes all night, oh, sweats, oh, you know, migraines, if we're dipping down below those thresholds chronically, and we give you hormone replacement, we bring your levels up just like this, you might not hit these thresholds so much, and you might just have a lot more stable outlook throughout all your hormones for the month. So we're not fixing this. It's like your ovaries and your brain are like, I got you, girl. No, I don't. Okay, I got you. Okay, let's have a period. Okay, we can't. And they're fighting because these ovaries are trying to keep up like they were 25, and they're not. They're 40 something or even pushing 50. I'm just
thinking about that, like testosterone don't be like that.
No. Testosterone, you know, that's what I was actually thinking about as you're talking about this, is like,
it's so much easier.
Yeah, testosterone is this just gradual decline. And it's interesting because actually the symptoms of low testosterone, very similar.
Or similar. Yeah.
The
Exactly.
difference being is that it doesn't seem like it fluctuates so much, meaning that, you know, we have this gradual decline as you get into your, you know, it kind of depends on the person, just like with women, you know, sometimes in your 30s, sometimes in your 40s. I also want to point out that I feel like definitely seems like genetics, at least anecdotally in clinic, where I hear guys are like, hey, look, dad and uncle and grandpa all
What was
have
your
low
dad's testosterone
Yeah.
like?
So, well, some guys will casually like mention that they're just like on the, you know, to their son. Oh, you feel like garbage? I'm on testosterone and it made me feel better. You should maybe go get it checked out. And guys do the same thing that women do, right? They gaslight themselves into, I'm fine.
I'm just getting older.
I'm fine. I'm just feeling crappy is just how I should. But the thing that I get from the guys end, Caitlin, and it's something that we haven't actually brought up symptom wise, at least you might've mentioned it, but I'm not remembering it, is from the guy's perspective, because they're going through their changes. Oftentimes they'll start talking about their partner in many cases. And the biggest one, of course, that gets brought up with them is libido. And so I'm like, I think this is something that we're kind of conditioned to believe that this is just how it should be, that women should just stop wanting to have sex. And of course we know there's a lot of psychological factors there. What's their relationship life, things like that. But if in another word, that otherwise good relationship where sex was common and good and everyone was happy with it, and then all of a sudden a woman starts changing, and but what the man brings up to me, they're not talking about the woman's sleep, they're not talking about the hot flashes, right? The men bring up to me like, hey, all of a sudden my wife doesn't want to sleep with me anymore, and
the libido's tanked, and that's a big deal.
What is your perspective on that? How does that all play in?
I think there's a lot of variables, obviously. Like if a woman comes into me and she's like, I've got this going on, and my mother just passed away, and I'm sweating all night, I don't feel attractive, I'm gaining weight, and all these things. And if they tell me the last thing because I'll be like libido, motivation, muscle, there's all these kind of testosterone-ish questions. And they're like, and we have a conversation. I say, what was it before? And they'll say, oh, it was pretty good. And I said, how are you feeling about it now? And they say, I don't know that it's my priority. And I said, that's okay. Because if you don't feel great about where you're at, body, mind, emotional state, I don't particularly know any dude that wants some woman that's just laying there. I don't. Like part of a relationship is the connection. And, and my hope and what I communicate to my patients is, hey, let's see if we can get you feeling better about your body, feeling like it's yourself again. You got to remember, a woman starts out as a teenager. She has a period at 12, 13, 14. Her body's not her own all of a sudden. Nothing makes sense, right? She gets used to it. Then she's in her 20s and 30s, having babies up and down, weight gain and all that. Her body's not her own. She hits her 40s and she thinks, heck yeah, I'm done having babies. I finally get to have my own body and have hobbies, and maybe life's going to settle out. And then you hit freaking perimenopause. And then you're like, my life's not my own. Can I just win? Can I just win 1 minute? When you look at a woman's life across their lifespan, like mental health and hormone wise, it's really frustrating because you finally thought like, yeah, I'm going to go do humanitarian projects. I'm going to serve people. I'm going to have hobbies. I'm finally done taking care of little kids that need me all the time. I get to do me. And then you got nothing. So when there's another human that's coming in and saying like, hey, I need you, you're kind of like, I don't even got me, so it's hard. And so usually when I talk to women about libido and I say, how is that for you? Are you worried about it? And some of them are like, yeah, I actually kind of miss it. That was enjoyable. I miss that connection. I have a really great relationship. I feel bad for my husband, but I just got to get some stuff sorted and get back to that mentally. And I'm like, I love it. If it sounds like a purely testosterone issue, like to where they're like, yeah, I don't get it, this is not me at all, and there's not these other variables we can isolate, we check a level and we can replace it. And that's the easiest part of my job. But a lot of times
that's the men's side of it, right? Like ours is pretty straightforward. And so I think what I hear you saying is you're like, hey, it doesn't matter even if a woman like libido is probably like almost in some cases like a secondary it's
Yeah.
like they feel so crummy about kind of all these other factors that
Yeah.
of course their
Yeah.
libido is not great. So
Right.
you fix those things, and usually at least we would expect that it would return to baseline given everything else is
Right.
fine.
Yeah.
Yeah.
And my stepwise approach is we start with a little progesterone, get them sleeping better. If they're not exhausted, hey, that might help with libido all by itself. If we're not like eating out of control the next day because we're miserable, exhausted, and drinking a ton of caffeine, right? We work on estrogen next. So that's the next visitor too. We optimize that. And then we work on testosterone. It's hard to work on libido, fatigue, and motivation when it could be progesterone and estrogen. And those are our two big wheels on the trike. You know what I mean? Those are the big ones. So I kind of have to do them all in a stepwise approach, because if I hit them all with all these hormones all at once and something doesn't agree with them, we don't know which one to take away. And so that's why it is hard for a go-getter that wants to just come in, see me one time, and I'm like, listen, it's really challenging to do it that way. But I think most women, when they're just being listened to, you know, I can tell that they're safe, they got a safe, good relationship, they're valued, they're respected. We just got to get them feeling a little bit more like themselves, get them feeling rested, get their bodies feeling like they're their own self again. It usually resolves itself. And then, you know, if we got to do a little testosterone at the end, great. Do it all the time. I get it, girl. Like, I'm happy with that. That's easy. So,
So I think we're going to get into a little more specifics on how to fix the problem. I think I wanted to just talk about another thing that I think, you know, we started this really because of the weight loss issue, and we've been talking about that for months now, and healthy lifestyle changes, and that's been kind of our mantra. I just wanted to maybe touch on that for a second, like as part of this experience during a women's lifespan, and these hormonal changes that we're talking about with the reproductive years and the perimenopause. One of the things I think that gets I don't know, maybe gaslit or just forgotten about, or isn't part of the conversation, is that one of the things I think that women will experience, and I guarantee there's people that are going to hear this and be like, yeah, that's exactly what I did, is that like the same thing that worked, the same exercise program, the same dietary restrictions that have worked for my life don't anymore.
Don't work anymore.
Like, this doesn't work anymore. I can't, the same old thing. It's not working. I'm getting heavier, and I'm doing the same stuff, and it's not helping me anymore. Like,
yeah, I think the way that I hear that is, and I think that me and you have talked about this before, Caitlin, is that I haven't changed anything, but my body's changing.
Yeah.
Right. Yeah. And it's super frustrating for women, because that's one of the biggest ways they know their body. What, for good or bad, our society has women tracking their weight pretty close. There's a few women out there that are like, I don't know, I don't worry about it, I just care about how I feel, which is amazing. And I love that. But a lot of times that's, you know, like I said, like the third complaint I have, you know, the third most common one I have. And then when I can say, hey, you know, if you're doing everything you've been doing, and, you know, you're going and you're working out every day, or you're even walking every day, and you're eating pretty good, and you're like, yeah, I understand. And there's variables. There's just so many more variables. And these hormones, you know, when we can get cells more at a balanced homeostasis, like the teeter-totter's balanced a little bit better, those cells know what to do better. And if we give them the right instructions, we give them instruction again with these hormones, so to speak, they know how to move insulin differently. They know how to build
we don't want to
muscle and
forget that
retain it.
estrogen drives that insulin sensitivity and the
It's
efficiency
huge.
that your body stores fat are affected by these estrogen fluctuations.
Well, and I think the third key to add in there is, which I know we're going to talk about a little bit, is you add in that third leg, which is cortisol, which me and Rick have talked about in previous episodes as being, you know, such a huge factor in driving some of this stuff.
Yeah, fat
and
storage.
I actually have handouts that I give to some of my patients, but it's basic. It sounds really hokey, and it's kind of a funky handout. But when I got into researching a lot of this, you know, when we're in our 40s, technically, right? Most of us women have teenagers. Sometimes we've got older parents that we're now taking care of, or there's some bigger problems. It was almost easier when they were in diapers because we could control a lot more. Once they're older, it's a little difficult. We've got a lot more life stressors that have huge impacts. And so I talk to women a lot about like balancing overall wellness. It's not just like, hey, we'll throw some hormones at it, you'll be good as new. It's definitely not that. And I literally have a goal sheet that says, this is what I do now. This is what I want to do. This is the ways to improve it. And I have some women actually take this home. I know it sounds hokey, but write down a few goals, see what you can do. If you've always wanted to take a painting class, now's the time to do it. It's not going to be later. It's not, you know, like we need to start taking care of ourselves and reducing cortisol because that drives insulin resistance.
Yeah.
It's a huge variable, and a lot of more standard providers are like, oh, I'm not going to check a cortisol level, and I don't necessarily check it because I say all the time, but I say to women, I say, hey, guess what I'm going to tell you if your cortisol's high?
Yeah.
Diet and lifestyle.
It doesn't change. I could not agree with that more. I get that question all the time.
Yeah.
And men even ask me all the time. Women ask me a lot too when I see them in clinic, and they want their cortisol level checked. And I'm like, I just, are you stressed? Like if you're stressed, I can argue, especially if chronically stressed, I can tell you your cortisol is up now, or if it's not later and you're still chronically stressed, it's probably because now you're in adrenal burnout. And the answer for that is going to be the same things. We can talk about supplements to support that, but ultimately the fixing the problem, no matter what we find, is going to be the same thing. It's sometimes, and I hate to say it like this, but sometimes when you look at someone's throat that has strep throat and you know it's strep throat, you're like, we can do a rapid strep test.
That's wrong. That's 20% of the time anyway.
Right. But I'm probably going to start you on antibiotics.
Yeah.
And so
it's a challenge. And a lot of women, and I've had a few really cute patients who I'll look them in the eye and I'll say, listen, I can tell you are the best mom, and you are the best wife, and you are the best daughter, and you are the best Relief Society president, and you're the best at everything, and you're amazing. But you need to start saying no. You're in grief overload. You can't recover from one high cortisol event like a death in the family and then a car accident and all these things. You're not having time to recover and get your cortisol levels back to normal before you got another bump. And we can't control those things, obviously. But I tell women, what you say yes to means you're saying no to your family. It means you're saying no to your health to some extent. And I'm not saying say no to everything. You know what I mean? I'm not saying, you know, you got to turn down every calling and every opportunity and everything. But I say you got to start being more selective. You got to look your husband in the face and say, honey, I need help with this. I need this to be your job from now on. I need, you know, mom, I need this, or maybe sister can help you with this or something. You got to start delegating, because if you don't start retaining some of yourself and recovering from some of this and breaking it just down to the basics and getting your wellness back, you're not going to be around for the grandkids or for other major events. You're not going to be feeling great and optimized for that. And so, and I don't say that to everybody, but man, when I can look them in the eyes and I'm like, you are crumbling under the weight of all this. It's okay to say no to some things. If you keep telling everybody yes, that means you're saying no to important things that are going to get you wellness later on. And so, and usually they tear up and they're like, you're right. And I said, girl, there's 24 hours in a day. You deserve an hour. Go to a yoga class, go to a painting class, go read your book and tell everybody, put your phone on mute. You get to do those things. You're at that time of life. And so it's really hard. I call it cortisol rehab. and I usually tell these women, when you come back in a month, I want to hear how you're taking care of you and how you're just desensitizing, you're calming your cortisol, you're retraining your body into a slower pace, because some of these poor women are just barely hanging and they're crashing by 2 p.m., falling asleep, standing up, basically, because they're so burned out. And there are medications for that. Nobody wants them. Nobody wants to go there, and they're for extreme cases.
So let's we're going to keep you on for next time, and let's talk.
We went 40 minutes.
We did. Yeah, we've been going. I told you we could talk about this.
I'm talking too late.
I did not realize we'd gone.
We'll move into next time a little more specifics on what to do about this, what to, and it's going to be a lot of reiterating of some of the things we've talked about again and again.
Yeah.
But so just kind of summary, that understanding this hormonal timeline of a woman's kind of life or lifetime, it changes the conversation from like, why can't I just try harder maybe to what does my body need right now? And that's not always going to be the same thing, but there are things that can be done that are both healthy right now and will protect your aging years and make them much more livable, enjoyable, healthy, less risky.
Yeah. And I think that really goes to speak of when we're talking about this, and you can see we can't even cover it in, what's going to be 3 episodes, how do you expect a primary care provider to figure all this out and treat it effectively and get to the real problem in 5 minutes? And that's why a lot of people don't they're not really aware of why it matters who you go to seek help for this. I mean, geez, if I'm a woman, Caitlin, just listening to you talk, I'm ready to book right now.
Give me an hour. Give me that hour.
Come on. So I think it's really important to point out that like a lot of people don't really understand that this is not it's a little bit of an art and science kind of all mixed in, and understanding all of that. And that's why Rick and myself are so adamant that you find a healthcare provider that you can talk to, that's going to dive into this and help you with this. And that's why we always are pushing that you find someone that will do this with you. It's very difficult to do this on your own.
Right.
Awesome.
No, I agree.
Well, we'll end it there, and then we will be back to talk about some more specific things on what to do about this. Thanks a lot, and we hope you all are healthier ever after.